Morning. My name is Ali Kiapour. I'm the Director of Biomechanics Research at Mass General Hospital in Boston.
Good morning. My name is Kris Radcliff. I'm a spine surgeon in New Jersey. I'm on the faculty at Thomas Jefferson University in Philly.
Thank you, Dr. Radcliff, for your time and willing to talk to me about some of the new and emerging technologies in the spine surgery. So I've been watching some of your videos and also your recent work related to motion preservation for spine surgery. I just want to get your feedback and your thoughts about some of these new technology and motion preservation in the spine, so clinical applications and science.
Yeah, so fusion's been around for a long time, and it's tried and true, and it's very good for relieving symptoms that patients have, for specific problems. But obviously, there's a long-standing concern that's been borne out in some of the research, including your research, that fusion may transfer stress or pressure to other parts of the spine and therefore cause those other parts to wear out prematurely. And, that's what we call adjacent segment disease. So motion preservation or disc replacement or it's really motion preservation now kind of emerged as a way to stabilize the spine, meaning hold the bones where we want them to be without necessarily locking them in place and creating all the mechanical problems that result after a fusion. There's a couple different ways to do it. The discs are on the front of the spine. A lot of patients are always confused by that because they feel the pain in the back of the spine, but the discs are kind of on the front. So disc replacement entails an incision on the front of the spine, either on the front of the neck or on the front of the abdomen. And then the disc is removed and it's replaced with a ball and socket joint of some kind. And then there are some other newer procedures that are done through the back of the spine, kind of like traditional discectomy and laminectomy surgeries. And so we can certainly talk about those as well.
Perfect. Thank you. So I've done some biomechanics research regarding motion preservation devices and comparison, again, conventional fusion. So, a decade ago, almost there was a lot of startup companies who wanted to get into that space. So for lumbar motion preservation and cervical, but there were some challenges back in the day regarding the materials and design, options. So which basically puts lumbar devices at a kind of risk of having a long-term success rates and given the materials and failure of the pulleys and dislocation and all that. But today, so we're talking about some new technologies such as using elastomers for overcoming some of those challenges that we had back in the day. And I see that this is a really emerging technology. So what are some of the challenges that you see?
Just tell me a little bit about your research. Do you have a sense of how much the pressure or the movement of discs adjacent to a fusion is increased? Like, is it 25% increased? Is it 30%? Because that often comes up. We know there's some increased pressure, but is it really significant or not?
Yeah, exactly. So great question. So when it comes about we talk about the motion at the adjacent level. So that's a big shortcoming, a limitation of the fixation construct. So we end up having 10 years later. So adjacent segment disease. So the idea behind the motion preservation is just we basically maintain or preserve the motion of the adjacent segment. But so when we talk about the kinematics in the spine, so there are two parameters that we are looking at. So a lot of people look at the overall range of motion. We're just trying to preserve that. But it's not all just about the, I would say, quantity of the motion. We'll talk about the quality of the motion as well.
That's a really good point.
So we have, if you look at the some of these literature published by Dr. Punjabi, who's a godfather in the biomechanics of the spine. So we basically demonstrated that the motion of the spine, the functional spine unit, is completely nonlinear. So if you look at the load versus angular rotation graph, so it's not a line. So spine stiffens up as you go to the extreme range of motion. So the goal is just to replicate
like a rubber band. It gets harder to pull as you stretch it more.
Exactly. And there is another parameter which we call instantaneous axis of rotation. So it's not a ball. It's not like a hip joint, which is a ball and socket joint. So it basically it's a shear and its rotation.
Yeah.
So if we have a technology which basically can replicate that motion, the quantity and the quality of the motion, now we can say, okay, so we can basically preserve the motion of the adjacent segment.
Yeah.
And that's what I've been seeing in my research.
Now with just to follow up on that, so global motion, patients always ask about this. If I get a fusion, will I be stiff? Will I not be able to move as far?
Yeah.
As the Harvard biomechanics professor, what are your thoughts on like global motion, meaning just macro, what we see, what patients, can they bend down and tie their shoes and things like that? For a one level fusion, is there a noticeable difference in overall movement?
Yeah, that's a great question. Yeah, I mean, it obviously depends on a variety of factors. So it's from the biomechanics perspective. So it comes at how many levels are you basically doing the procedure on? So if you have multiple levels, now that patient might be able to basically notice the difference.
Yeah,
so
multi-levels.
Multi-levels,
yeah.
But a single level probably is not noticeable.
So my interest in motion is more on the kind of the individual discs. Mm-hmm. And I feel that in my hands, especially with a one level fusion, the difference in overall motion that you can see or kind of gauge or measure is really negligible, because what happens is the patients are not impaired by pain anymore. Mm-hmm. So when they're bending and twisting and moving, they actually can go a little further because it doesn't hurt. Mm-hmm. Whereas before the fusion, there often is some pain that limits them. Mm-hmm. So the challenge with disc replacements in my hands is that, it's really, for a very specific patient population. Yeah. And the original kind of studies and the original data were in people with sort of structurally pretty perfect spines, normal disc height, and no bone spurs and things like that. And it really wasn't intended for use in people with arthritis, or it wasn't studied in that population. Mm-hmm. And so consequently, I find that the ideal disc replacement candidate for me is someone with like a cartilage problem, a disc herniation that's a soft herniation without underlying bony issues. Mm-hmm. So in the cervical spine, we get herniated discs all the time, and we can, remove the disc and so forth. In the lumbar spine, I find that it's mostly for recurrent disc herniations. Mm-hmm. Sometimes if you leak out disc, you get a discectomy, then you leak out some more disc. Mm-hmm. About 20% of the time, you get another discectomy. Mm-hmm. And if that keeps happening over and over again, the remaining disc is just drained. Yeah. So then they hurt. And I find that that disc replacement is a great solution for that post-discectomy back pain, because cartilage-wise, they're usually have some issues, but bone-wise, they're okay. Mm-hmm. I've always struggled to find a solution that's really applicable to Medicare patients, older patients, the kind of like the larger patient population who generally fall within Medicare. And there's some challenges with getting disc replacements covered by Medicare. So there's a couple of new solutions now that we can talk about that are basically ways to preserve, stability of the spine and stability. Well, tell me, what does stability of the spine mean?
Good question. So stability, it's a very general term, but from the biomechanics perspective, so we talk about the controlled range of motion. Yeah. So we have obviously the anterior column, we have the posterior column, which are the facet joints. And I think to your point, so stability is probably one of the number one maybe goals from the biomechanics perspective, and these procedures. But yeah, we want to make sure that whatever procedure is done, so it does not put additional stress on the surrounding tissue. So for example, let's say if we do a disc replacement, but what happens to the posterior facet joints down the road, a year or 2 years? Do we end up having the facet joint degenerations and all that? Yeah. So stability is not always just the controlling the range of motion, but also controlling the load distribution with the adjacent tissue. Yeah. So that's my understanding from the stability in the spine. Yeah.
And interestingly, as a clinician, my understanding of stability is more, do the bones stay where they're supposed to be, or do the bones move in some abnormal way that damages the nerves? Yep. And so for me, something is I'm more likely to call it unstable when the bones move in such a way that it's damaging the nerves. And just to be clear, I mean, we all have in almost all of our joints some abnormal extra motion. And it's hard to differentiate extra motion that's a problem versus just extra motion that's just kind of how the person was built. Yeah. So two solutions. One is called Balance Back. It's by a company called 3 Spine. They're certainly doing a lot of research and some presentations at this North American Spine Society meeting. And the beauty of it is that can be done in accompaniment with a laminectomy. So if someone has spinal stenosis, if they have overgrown facet joints, if they have arthritis, you can do the normal surgery to relieve the sciatica part, and then you can stabilize the spine. The other device, which I happen to have a model of, is it's called TOPS. Yep. And so it's very similar. And so for most spine surgeons, this will be very familiar. For patients, this is often terrifying, but the idea is you can put in screws into the bones in specific places that like we normally do, but then instead of having it become fixed and rigid, there's a special joint inside of here that can bend and move and allow some movement. Now, the overall amount of movement is still pretty low because each individual disc or level only moves couple degrees usually, but the net effect of being able to move and bend and twist even a little bit is that we think that there's less pressure on the levels above and below. So this was just FDA approved in June, and it's kind of becoming more commercially used now. But I think that those two solutions specifically really increase the toolkit that surgeons have to take care of patients and allow us to treat a much broader range of patients without fusion.
Okay, perfect. So I have some questions about this technology. So I know like back in the day we were talking about isorods and dynamic stabilization.
Yes.
So instead of motion preservation. Is this considered more of a dynamic stabilization as opposed to the motion preservation? I mean, your goal is just to stabilize the construct, but not necessarily replicate the entire motion of the FSU. So it's not going to deliver the intact level motion, but it's not going to be like fusion.
Yeah, I'd have to look at the biomechanical data and see how much movement is it relative to what would be normal. Yeah. I do think it's fair to say, though, that it is, at least philosophically, fair to call it a dynamic stabilization, because this can be done in someone who has like abnormal front-back movement of the spine, which we call a slip vertebrae. Yeah. And even if you don't like quite pull the slip vertebrae back to its original position, you could still put in a device like this or the 3 Spine, and there's a couple others on the market, and at least, you're right, stabilize it and keep it from sliding and moving more.
Yeah, exactly. So, and can you please elaborate a little bit more about the surgical procedure, which is like done to place a device, and like, do you do facetectomies, what ligaments are removed, and so on?
Yeah, so there are kind of I guess 3 different genres of spine surgery. There's surgery solely to open up space for the nerves, which is usually an ectomy or an otomy of some kind, laminectomy, laminotomy, foraminotomy, something. And that means that there's a nerve somewhere that's compressed and we want to open up the space for it. And so that usually is done through a traditional incision down the middle of the back on the low back. And that surgery has been around for, over 100 years or longer. During the course of that surgery, there are these joints that are kind of like little, I compare them to knuckles on the back of the spine, but they're called facet joints, and they bend and twist and so forth. And so those joints can be cut out and removed. And the idea is that by removing those joints, you increase the space for the little tubes where the nerve exits the spinal canal, called the foramen. And so the technique for this and for the balance back procedure is that you remove the entire facet joints. So patients, there are kind of 2 parallel trends in spine surgery, of minimal invasive, and I know we've heard about that a little bit even in this forum, as well as motion preservation, and in general the surgeries to preserve motion, like artificial discs or even like this kind of procedure, they're not minimally invasive. So people are going to have a standard incision, 6 to 8 inches long. They're going to be in the hospital overnight. It's done in a hospital, and the recovery then is usually in the order of months.
Okay, perfect. So I had another questions related to the patient's conditions and qualifications for this kind of surgery. So I know, like, for example, for interbody fixation, so we'll look at the patient's bone quality. So to pick the right implant size with enough sufficient contact length with the metal. But is there any exclusion criteria when it comes to this kind of procedures? So does it have to be a certain bone quality for a patient to be qualified for a procedure like this?
There's not a specific bone quality criterion. These screws have a special surface coating to maybe help bone grow into them, because there was a concern on the part of the company and on the part of some of the surgeon investigators that the screws would pull out or loosen with time. But there's not specific criteria. I think that to some extent, this may be a better option than interbody fixation, meaning removing the disc and putting a cage in patients with bad bone quality, because we often see that it's subsidence on the cage side, where the cage starts to dig into the bones in a way that's undesirable. In general, this surgery, which would be called a posterolateral fusion, putting in screws and stabilizing the spine, it is more commonly performed and more applicable in older folks. So interbody fusion improves the fusion rate. But if you're not going for a fusion, then I don't know that you need, an interbody device, such as a cage here.
Absolutely. That makes total sense. Yeah.
There obviously are other, it's single level, no fractures, no tumors, no infection, that kind of thing. But the real tricky part for all these procedures is actually the surgery is much more technically complex, because the screws have to go in almost perfectly in order to fit the device without having it be uneven. It's kind of like the way you have to have an alignment on your car. If there was like extra pressure somewhere, you might wear out one of your tires more than another one because the suspension would be otherwise off. This surgery, you have to really think about the suspension of the spine, and by getting the implants perfect. And so it takes longer. It's a little more involved, but maybe it's worth it long term.
Very good. So I had another question related to motion preservation devices for spine in general. So one of these basically challenges when it comes to the design of these devices is to fine tune the mechanical properties of these constructs. So know that from the spine biomechanics perspective, so we have like 3 anatomical planes of motion, like sagittal, coronal, and transverse, so 6 different motions. So are there any specific motions which are much more relevant and important for fine-tuning this mechanical properties of these devices, and that's what your goal is for motion preservation?
Yeah, it's a great point. And, we talk about the motion in like discrete directions, but you of course know this, that like most of the movements are coupled. We don't just purely bend off to this left. We kind of bend left and rotate concurrently. And so it's really, I think the bending and coupled with rotation that are, I think, important for quality of life. I mean, we twist our trunks all the time while we're in conversation with friends, when we try to tie our shoes, if you pick something up off the floor. So I know that flexion extension range of motion kind of gets a lot of attention, but really I think it's rotation and bending that are more important for people going through their day and their lives.
Exactly. So that's very interesting. Yes, to your point. So we see that always in biomechanics research. So it's very important how to set up the models to show that coupling motion because of the muscles and co-contractions of the muscle synergies and all that. So, and for cervical spine has a different biomechanics compared to lumbar spine. So lumbar spine load sharing is very important. Cervical motion is important. So the direction of the facet joint change as you go from the lumbar to the cervical, that basically changes the plane of the motion.
In the cervical spine, the disc replacement is, I think, a much more mature technology, as it is in lumbar spine also. But there's good 10-year data now for multiple implants, and therefore there's kind of, I think, really good predictability now to be able to say, this is how people who have disc replacements, look 10 years later. And like any other joint replacement, we're starting to see wear and just like knees and hips and other joints can wear out. And I think that as a community, we're still figuring out how to handle that, the wearing out. And then on the science and research side, we're looking at are there new surfaces or ways that we can make the disc replacement to minimize wear, because we know that wear ultimately could land patients back having to have another surgery.
Very good.
Either way, it's important for people to have good posture, good core strength, to try to move and do comply with therapy and things like that. So it's not just the surgery, right? It's the whole
setup,
the whole
system.
picture.
Yep, perfect. Thank you. So a lot of great information. Thank you for your time today. Unless you have any other questions for me, so we can conclude this session.
Yeah, I just had a couple other questions. So, currently kind of most of our implants are titanium.
Yeah.
And there are 5 or 6 titanium alloys that are around. Yeah. Do you see us using other metals? And are there like in the future, are there advantages to other metals? Because first of all, patients are always ask, what are the screws made of?
Yeah.
And titanium is not super familiar to most patients. Yeah. They say, well, why is it titanium? I'm like, well, it's good MRI compatibility. It's good with bone. Yeah. But are there better surface materials out there? That's
a great question. So thank you for asking that. So yes, I mean, there have been several materials which have been used for manufacturing of the spinal hardware. So titanium is the most basically common one because it's pretty strong, very good by compatibility performance. But so even with titanium, now we are talking about different grades of titanium. It's a medical grade of titanium, and then there is the pure titanium.
Yeah.
So the pure titanium is a little bit softer than the medical grade titanium. So it does not survive the same static loads as the standard titanium, but it is softer and it has a better fatigue properties, meaning that when you go through the cyclic, basically loading, so it's not as brittle as the standard titanium. So there are some opportunities there, and some of these manufacturing companies which I've been working with and talking with on some projects. So they have developed some technologies to use the soft titanium, pure titanium.
Yeah.
And for areas, so we're talking about the motion stabilization, so let's say dynamic stabilizations, or have the inner body devices which conform to the shape of the profile of the end plate. So, and also we have other materials, emerging technologies such as nitinol, so which has been widely used for cardiovascular procedures.
Yep, stents.
It's a stents. So, but nitinol is a super elastic material. It can be straight. It doesn't ruptures.
Yeah.
So maybe there are some opportunities there for some spacer designs or stabilizations and much.
One other thing, a more broad question for the surgeons who are looking at when someone approaches you with a new device, what biomechanical factors do you think surgeons should look at as they're evaluating if it works or not? And obviously there are clinical studies that usually accompany most new devices, but should people be looking at FDA studies and wear testing and things like that? Should they be looking at particle shedding? Should they just look at forget the biomechanical studies, because once they kind of pass the FDA, they've already passed kind of a common hurdle. Yeah. What advice do you have for surgeons evaluating new devices?
That's another great question. Thank you. So, yes, obviously, the number one goal of any kind of a study, engineering analysis on these devices, is just to make sure they can survive the loads and requirements defined by FDA.
Yeah.
But one of the challenges there is, actually FDA published 2 articles a few years ago for summarizing the mechanical data for FDA cleared devices for cervical and spine. So they basically had a table in those articles which basically showed the acceptance criteria for static loading at different percentile.
Yeah.
So when you look at those load data, obviously those loads are much larger than the biomechanical load that you see in the body. So if you want to go with those loads and optimize your devices, so you're still over-engineering at some point, so your devices. So I was always looking at this from this perspective. So if you look at the hardware and then you have the adjacent bone. So the bone is much softer than the metal. And so the chance of you basically breaking a metal implant inside the body is much lower than the damaging the surrounding tissue. So we're talking about like in a couple of thousand newtons of load this is required to crush the bone, even the strongest bone. So that's basically one of the biggest challenges. But as engineer and biomechanics research experts, so what we typically do is we do two types of studies. One is the biomechanical study. Regardless of the acceptance criteria, they put the device in using computational models and just try to replicate the anatomical motion and see how the device performs. So let's say if the goal is to preserve the motion, so we'll simulate that at a computer and see if that happens, compare that against intact spine. Then there are these other set of studies that we do which requires mechanical testing and just test these devices against the guidelines defined by FDA, so feasibility analysis, and see if the devices are strong enough. So we can use all of these data and help the surgeons to develop the technology and engineers also to optimize the design.
One other question, it's kind of clinically relevant, but if, for example, a rod breaks or hardware breaks, which instrumentation breaks, which happens periodically, the patients inevitably ask, well, how did that happen? And they kind of think that they should have had a fall or a trauma and that you need some like major high force event to break hardware. It sounds like you're saying that it's the opposite, though, that it's not necessarily a single traumatic event like a fall. It's more just like gradual bending over time. Is that fair?
Yeah, exactly. So, that's a very interesting point. So, when we talk about the hardware failure, so we're talking about two different, basically, phenomena. So, one is the failure of at a tissue implant area. So the screw loosens up, backs out. So we have this in this long deformity construct. So the screws at the far end. So obviously at the higher risk of failure. So they pull out. The hardware does not fail necessarily. I mean, it's not the failure or rupture of the screw, but the screw pulls out. So that's considered a failure.
And that's a known kind of result or complication of long fusions. Like if you get a T10 to pelvis fusion, you may see some loosening or pull out at T10.
Exactly.
Yeah, okay.
And then we have the failure of, as you mentioned, the rod. So the rod is a key component of like fixation construct, posterior construct. So it sees a lot of loads and bending moments, and then we have the daily life activity. So in engineering and for FDA requirements, so we test these at 5 million cycles. So assuming that this hardware survive repetitive load at 5 million cycles, basically, which takes into account the amount of bending that a normal human does during the certain number of years and so on. That's the acceptance criteria. But when the hardware fails, so because metal is typically soft, so it's not like ceramics, which shatters into pieces and leaves shrapnel.
Like China, like porcelain.
Yeah, exactly. It fails gradually. So we have this necking process. The material, just keep bending that back and forth. So it fails. Eventually, we have crack, and the patients, it's likely that they do not even notice. It's just the effect shows up as a pain or some sort of infection, I think. But that's basically some of the areas that we are just trying to investigate with biomechanics research.
It's really interesting. That's great.
Very good.
Well, thank you. It's been a pleasure. Thank you very much.
Thank you.
Likewise.
Shake hands.
Thank you.
Thank you.